Assalamu alaikum. Welcome to this workshop. I'm very pleased to see you all here. My name is Gillian Saalوجي. I'm coming to you from South Africa. And I'm really delighted to be back in this country. I was here 12 years ago, and it is just remarkable, the progress that I've seen in such a short space of time. I also just want to thank the organisers, the King Sultan Disability Research Centre, for inviting me, and I want to just thank everyone that I have met since I've been here for the incredible hospitality and generosity that I've seen. I don't think anyone does hospitality as well as the Saudis do, so I want to say thank you. I must also tell you that I'm not always used to having such a barrier between myself and you, the audience. You're seeing very far away. So I wanted to know if it would be okay, because we are a small group here, for you to tell me a little bit about who you are and why you've come to this workshop. Take one barrier away. Can we start on this side? Just to introduce, or can we start over here? Just to introduce yourselves, just so that I know a little bit about who is here in the audience, who we're talking to, so that I can make sure that I'm giving you information that's going to be useful. Thank you.
You can just speak in the speakers that the translator can translate.
Ah, thank you. I think you all have speakers, so let's use them. I think there's a button you've got to push on.
My name is Amira. Psychology. My name is Amira.
My name is Ghaida. My name is Ghaida, Special Education.
My name is Shurug, a student of Special Education.
My name is Afnan, student Special Education.
My name is Dinan. I am physical therapist at Child Developmental Center at Denmark.
My name is Ruzia. I am in Brazil University. I learn learning disabilities. My name is Fat. My name is Rima.
I think I have to stay behind the microphone so that you can also then to help the interpreter. I would like to ask your help as we start this presentation, that if I am talking too fast, please wave your hand. It will really help me to make sure that I pace myself to make it easier for the translator. So, may I just ask a show and ask you to, all the therapists that are in the room, would you mind standing up? Anyone that's a therapist? Who are the therapists here? Okay. We do some physical activity here. I'm a physio. Okay. So those are the therapists. Okay, thank you. And the teachers or anyone connected with education? Special needs teachers? Okay. Teacher? Students? Your students? Okay. Students, you are studying to be teachers?
Yeah.
Okay, thank you. And then I think there was, is it a psychiatrist? Physiologist? Yes. And a psychologist? Okay. So we have a mixed group in the audience. So let me tell you where I'm coming from, so that it will help to see a little bit about the background and where I work. That will help to explain why we're doing this presentation today. So I work for an organization called Malamulele Onward. Right, your first lesson in English today, Malamulele. Try it. Malamulele. Well done. It's actually a Shangaan word. Okay, and it's the name of the village in the north of South Africa, and that's where the project started. So Malamulele is a non-profit organization that works with children who are severely disabled as a result of having cerebral palsy, who live in rural, resource-constrained areas. So that's the group of children that I am working with, and this we have an office, a training center and a therapy center in Johannesburg. So that's the building where I work. But most of our work, all our work actually takes place in deep rural areas. So on your right-hand side, there is a map of South Africa, and all the little red dots will tell you those are the areas where we are working. And the green tree in the middle is in Johannesburg, and that's where our offices are. And then the child in the photograph and her grandmother, that is typically the kind of children that I work with. Children who have quite severe disabilities, who live in remote areas, who are not at school, and who do not have any access or very little access to therapy. Often there are no roads to where the children are staying. So, what is this presentation going to, what are we going to cover in this workshop? First of all, I want us to make sure that we all on the same page with who are we talking about. What is the population of children that we're talking about? What are their key problems? What should we be doing in therapy? And what are some ideas? So this talk is primarily aimed at therapists. But I do hope that the teachers and the students that are here at the end of this talk will gain some information that will help you when you are working with this particular group of children. So, who are we talking about? Are you familiar with the classification systems? Do the words GMFCS, MAX, CFCS, Level 5 mean anything to you? If it does, wave your hand. Okay. So I did prepare a small handout of this talk. I'm not sure where it is, but included in the handout will be what's on the slides and also all the classification systems. So I'm going to just go forward. And let's have a picture of the children that we are talking about. Okay. So these are two children. The young boy at the top of the picture, his name is Michael. We'll be seeing quite a lot of him throughout the talk today. And the one in the lower half of the picture is Direko. So these are two children who have severe forms of cerebral palsy. What do they have in common? What do you see? They're not doing much. Would you agree? Okay. So if I go back a slide. All right. So we talk about the GMFCS, which I'll come to in a minute. But these are functional classification systems that help to describe the severity of a child's disability, irrespective of the kind of CP that they have. So, they are children on the most severe end of the spectrum of children with cerebral palsy. In addition, they have many associated impairments, particularly epilepsy, cognitive impairments, and probably around 80% of the children also have a visual impairment. The children will also have quite severe feeding difficulties, and hip dislocations are almost inevitable in this group of children. So, in summary, we are talking about a group of children who have, I would say, the most severe impairments and that are totally dependent on other people for all their needs. So, a few minutes ago, I mentioned the different classification systems. For those of you that are not familiar with them, this has been one of the most helpful guides that has been helpful guides for understanding children with cerebral palsy. Cerebral palsy is no two children with cerebral palsy are similar. Some children are very stiff, some children move too much. And it's really quite hard, and there's very little agreement sometimes on what kind of cerebral palsy. Is this child spastic, or is he more dystonic, or is he chorea, or does he have a mixture? So these 4 different classification systems do away with trying to agree on whether this child's a diplegic or quadriplegic or spastic or dyskinetic. And instead it looks at what the children can do from a functional point of view. So there are 4 different systems. And if you're working in education or as a therapist, I think it would be really helpful for you to have an understanding about these systems. They are in the handout, and you don't have to go to a course or whatever to understand them. There's very good descriptors of them. So the GMFCS is about the motor system. So that is a system that tells you about how much the children can move. So in terms of their mobility. The MAX is the manual ability classification system, and that tells you about how much hand function the children have. The CFCS is a communication functional classification system, and that tells you about their children's ability to communicate, to understand, and to be understood. Then the last one, the eating and drinking classification system, is about the child's ability to obviously eat and drink. Each of these systems is divided into one of 5 levels. So here, for example, is the 5 levels of the gross motor function classification system. And what each of these systems, whether it's the MAX to do with the hands, whether it's communication, whether it's eating and drinking, what they all have in common is that the child at level 1 functionally has is almost able, what you would say has the most ability. Whereas the child that is at level 5 has the most severe degree of functional limitation. So if we just have a look at it from the just the GMFCS aspect, a child who classifies level 1. Are you okay there? Yeah. A child who's classified as GMFCS level 1 is a child who can walk, who can run, who can jump. and he can walk up and down stairs on his own. So this is a child, if you understand children with CP who may have a mild hemiplegia or a mild diplegia, may have some incoordination with running, with walking. But he can run on his own, he can walk up and down stairs. GMFCS level 2 is a child that can walk on his own, but will have difficulty with climbing stairs and will have difficulty with crowds. So he's got some problems with balance. He can't run. He can't jump. If he walks up and down stairs, he'll have to hold onto a handrail. But he can move around independently on his own. So that's GMFCS level 2. GMFCS level 3 is a child who can move around by himself, but either needs a walker or a wheelchair. But so it's independence. From a mobility point of view, they are independent, but they need some assistive device. Level 4 is a child who may be able to walk with a lot of help from 2 people. This child will be able to move themselves around on the floor. So they probably won't be able to sit on their own. GMFCS level 3 child will be able to sit on their own. The GMFCS level 4 child will be able to they'll be able to roll over, they'll be able to move around on their backs or creep on their tummies. Okay? And then you get your level 5 child. Your level 5 child will be able to maybe lift up their heads if they're lying on their tummies. They may be able to move from side to side. They won't be able to change their position, and they won't be able to move themselves, so they won't be able to turn over in bed. So that means whoever their carers are will have to at night turn them over. If you leave this child on the bed, a level 5 child, when you come back, you'll probably find the child in exactly the same position. Okay. So do you have it in mind who we are talking about? Your GMFCS level 5 child, a child who cannot roll, cannot change their position. So their degree of impairments are to the extent that it restricts or limits voluntary movements and being able to be able to, for example, be able to sit. At the most, what they can do is maybe lift up their heads. Okay, they may be able to roll from side to side, but they cannot change their position. All right. So there's 2 pictures of your level 5 children. So remember, this is the group of children that we are going to be talking about today. The other functional systems, when I say max level 5, this means that a child cannot handle objects, severely limited ability to perform even simple actions, and requires total assistance. In terms of the child's ability to communicate, this child is seldom an effective sender or receiver, even with familiar partners. So these are children that are difficult. You don't have a clue as to what they're trying to tell you. And similarly, you're not sure how much the child can understand. All right. So, the questions we may be asking ourselves. Can I just have a show of hands? Who of you have worked with the kind of child that we're talking about today? Put up your hands here. Okay. A few of you have worked with this group of children. Yeah. So those of you that have worked with them, can I ask you, do you think change is possible? Do you think there's any point? Sorry? Yeah? You will not. Okay.
Only after trials.
Sorry?
Maybe only after trials.
After?
Trials.
Yeah. So the questions we can are when we see this group of children can't move themselves, often can't see, cognitive problems, severe degrees of epilepsy, can't do anything with their hands, can't communicate verbally. One can say, can we expect change? What changes are likely? Should we be treating the children? When should we discharge the children, and what is the point of therapy? So what are we trying to achieve? And some people will say, well, why do we even bother? Good, to prevent, yeah. Okay, who was that made that comment? Right. Number one, top of the class to you. Okay. Because you want to, one of the things, why do we, although we may not be able to make a lot of difference in the children, without any intervention, what we can be sure about, the child can get worse. I want to show you, read through you two quotes. So, as I said to you in the beginning, I work with children in deep rural areas who have severe disabilities. South Africa is a country where we have 14 different languages, so I'm always working in a cross-cultural setting. And I'm working particularly in children from very poor areas, remote rural settings, where there's still a huge amount of stigma and a huge amount of ignorance about what it means to have a disability. And these were comments from two mothers when we asked them what attitudes were towards their child. And this is the group of children that we're talking about today, your level 5 child. The neighbors are worse. The other one even asked my mother, "Do you love this child?" My mother said, "Why do you ask?" She said, "Because this is not a human being. Have you ever seen a human being who looks just like this child?" So, in addition to a mother trying to make sense of this child who's got such a severe disability, she is confronted by neighbors and a community who do not even see her child as being human. Another comment, his grandmother, his father's mother, phoned and asked if the child is still alive. My mother answered her by saying, "He's still alive, and why are you asking that?" She said, "I'm asking because, to be honest with you, I do not love this child. A child who is deaf and blind and cannot sit isn't a child. What will I do with him? That's why I chased him away from my house. I even chased his father." So, I don't know how it is here in Saudi and what your experience is, but certainly there is a perception in some areas that these children with such severe disabilities are not even alive, they're not even human. They're useless because they can't do anything. So if I go back to you and I say, well, what are we trying to achieve and why bother? I want to show you what can happen when we don't bother. As the child gets older, the problem doesn't go away, it becomes worse. And here you have a child, a teenager, malnourished, incredibly thin because of the feeding problems, left lying on the floor all his life. What kind of quality of life do you think this child has? You want to ask something? Sorry, just say that again.
You said that feeding problems. You mean that kwashikor marasmus and that feeding problem? Which type of feeding problem?
Feeding problems. Okay, sorry, I've missed the slide that had the classification of eating and drinking problems. So it's a child that cannot swallow safely, a level 5
that
child.
That means all malnutrition diseases.
Malnutrition due to not being able to chew, not being able to swallow. Okay. So, if I go back and say, why do we bother? And it's very simple. Every person is important and every child matters. Okay. And I think if we are involved with children that have this degree of disability, we have a very important role to play to both the child and the child's family. And that role is to say, you matter. You are a human being, you're a child, and you matter. And CP, children with CP don't get better over time. The problem does not go away. And what we want to prevent is what we are seeing in these pictures here. The sweet little child who you see when he's very small is going to become an adult with CP. The joints are going to get stiffer. The muscles are going to get tighter. Pain is inevitable. If I go back to what we're trying to do in this workshop, we've covered the first point that says, who are we talking about? We're talking about a child who's got multiple impairments that result in severe limitations in terms of what the child is able to do and his ability to participate. If we have a look at understanding this child, and this is just a very brief overview or a very brief look at how we might understand the child's condition in terms of the ICF. In terms of the body function and structure, the list is endless. Almost every single system in this child's body has got some impairment. From a point of view, his postural tone, atypical tone. The tone is postural tone, muscle tone is either too high or too low. The child has got a problem with his visual system. The child's got a problem with the musculoskeletal system, dislocated hips, contracted, reduced joint range, reduced muscle strength. The child has got a cognitive impairment, epilepsy, severe motor impairment, incontinence. So almost every system that you can think of, this child has got a problem at the impairment level. In terms of the child's activity limitations, what can the child cannot change his position, is totally dependent on carers for all the daily needs, has limited ability to engage in any kind of interpersonal relationships. So this child's participation restrictions are enormous. Limited access to education, limited social engagement, limited opportunities to play. All the things that we take for granted, being able to play, being able to participate, being able to connect with other people, are a challenge for this child. So I would like to ask the teachers, there were some teachers and some student teachers in the audience. What for you would be a key problem if this child, if you were asked, if you had a child like this in your classroom? What would you find difficult?
Please, you have to repeat the question again.
So the question is on the board, and I'm saying for you, if you're a therapist or a teacher or a psychiatrist or a student, what for you would be the key problems in working with this child?
For me, okay. As I am psychiatrist, maybe I will, that might face that if there is that IQ level problem and the medical status of that patient, there is impairment. Impairment, that means maybe multiple disorders. That means multiple diseases in one case. Maybe a cerebral palsy with autism, maybe plus Down, maybe plus ischemic heart disease, maybe that may be collected diseases in one case. That means I have to differentiate firstly by the main problem in that patient itself. Firstly, I think that communication, maybe if there is the eye contact and the autism, and I think this is the mainly problem of my patient.
Maybe how I can take the take the perfect technology for him.
The child will not be able to respond to command, which make the therapy difficult for me because the cognitive status of the child.
I'm a physician, and my problem is how do I break through? Often I don't have a therapist where I work, and I'm not trained how to handle this, and I'm uncertain, and therefore I try to sort of push this away from me, not to get involved, but on the other side I know I have to. And how do I support the parents? I don't know how to support the kid, but perhaps I can support the parents, and that's because they're with him all day. Often they need more help than the kid, and how to do that. I'm even after I've worked in situations with kids like this, it's still a challenge for me.
As an OT, I think safety of the patient, safety of the child. Just
family counseling.
I thank you for your comments, and I think what you've said is all absolutely true, in that it's a couple of things that you've said. You need a holistic approach. So it's not just about the child, it's about the child and his family. Okay. You've also said to me that it's quite scary. We don't know how much the child knows, how much the child understands. It's really hard to make a connection with the child. Okay. So when faced with a child like this, it's okay to feel really scared and to say, I'm not sure where to start. And the other thing is that it's also been mentioned here, is that you've got to think that this is still a child who's totally dependent on us for all his needs. So how then can we best support the child's family? So if I were to summarize what the key problems were, I would put it into three groups here. The child has little or no useful or functional movement. If the child cannot move himself purposefully, example, to turn over or to change his position, what does that mean? That means that child will get stuck in whatever position he's left in. And if you don't move, if your muscles are not moving, if your joints are not moving through full range because you don't have a lot of movement, the little bit of movement that you got is going to disappear. So for me, one of their biggest challenges, this is a child who cannot move. If he cannot move, he cannot change his position. I think about that from a comfort point of view. If we get uncomfortable, we can just shift around. This child is limited to a few. It's not that he can't move at all, but the movement's not very helpful. It's not enough to help him change his position. There's a lot of things that bother me about working with this group of children. And one of the things I notice, because I work with the children often in their homes, is that they cannot swat a fly off their face. Now, if you are lying down because you don't have something to sit in, or you haven't, because someone was talking about technology, if you don't have a comfortable chair to sit in, and you are left lying on the floor or just sitting in your chair, and a fly comes to your face. Now, remember, the children have got, if they can't swallow properly, they often are drooling. Or they've got remnants, what's left over of their meal around their face. It attracts flies. If you and I have a fly, we can brush the fly away. I look at these children, they cannot even do that. So I think about their own levels of comfort because they do not have movement. We need to move in order to make ourselves feel comfortable. Secondly, the associated problems with cognition, with vision, make it extremely difficult for us to actually connect with the child. And I think that for me is one of the hardest things, that how do I find inside this body, inside this twisted body, there's a person. I want to get to know that person. This is a person that has some likes and some dislikes. How do I get to know what makes this person happy, what makes this child happy? And for me, that's, I think if you're a parent, it must be so painful. How do you form a bond? How do you form a relationship with a child that can't see you very well, that may not be able to hear you? Okay. And then in the long term, you've got to think about the effects of not moving has on all your systems. In this group of children, hip dislocations, there's over an 80% possibility, probably closer to 90%, that this child's going to end up with a dislocated hip because they are not standing, they are not weight-bearing, they are not sitting. So this child over time is going to have a dislocation, which is going to become painful. Contractures, malnutrition due to difficulties with being fed, and pressure sores. Okay. So therefore, it looks pretty overwhelming. So then what outcome are we looking for? And what can we expect? I think we have to first be realistic. We are not going to make miracles here. You are not going to change the child in terms of any of his functional abilities. There's no scales that exist that say, if I give the child all this therapy, I'm going to be able to see changes on a scale. Okay. So what we want to do, I think there are three things that guide me, is that intervention, ongoing therapy is absolutely essential. Because if you can just maintain what the child can currently do, and you can avoid deterioration, that's a successful outcome. And that's not often what we are trained. We are trained to look at improvement. In this group of children, maintenance is success. You want to, and that's what one of you said earlier, you want to reduce the inevitable deterioration that you are going to see in the musculoskeletal system as the child gets older. So any intervention that you do, you have to think about what's going to happen over time. And what do I need to be doing now to slow down the inevitable musculoskeletal deterioration that I'm going to see? And I want to do it in such a way because my primary goal here, or aim, is to make sure that as this child becomes a teenager, becomes an adult, is he comfortable and is he pain-free? Quality of life. I also need to recognize that any improvement that I see will be really small and changes will be tiny. And I will make a huge fuss over the smallest changes that I see. And you'll see just now how, for example, how we can work with the child's vision. And sometimes just to get the child to recognize or to look at a light or be able to follow a light. For us, that's a little miracle that we celebrate. We don't take anything for granted. So I think as therapists, as teachers, we've got to set very realistic goals and look for the little changes and the small changes. So, to summarize, when we look at all, remember I gave you the picture at the beginning when I looked at the ICF and says almost every system has an impairment. To try and simplify that and say, what do I need to do? What is the approach that I think? I want you to think of three things. I want to maintain what the child can currently do. Whatever sense of engagement he's got, I want that child to maintain that ability. That maintenance is a successful outcome. I want the child to be pain-free as he gets older, comfortable, and I'm going to celebrate the small changes. Okay. Some guidelines here. I'm going to show you some pictures of what happens, what can happen. We call it the cruel arrow of time. Cerebral palsy is a permanent disability. It's not going to go away. A child with cerebral palsy is going to become an adult with cerebral palsy. So what can happen to this child that has very little ability or very little useful ability to move? I've also got to think about the burden of care to the caregivers. This is a child who needs help 24 hours of the day. When I talk about caregivers here, I talk about caregivers in the broader sense. Mostly, the caregiver is the mother or the grandmother. Okay, so that's who I'm talking about. It could also be a paid carer. Right, so I'm using caregivers both as the child's family members, extended family members, or a paid carer. You've got to think, this person has to do everything for the child. What do I need to do to make their lives as easy as possible? And the way to do that is to, from an early age, to implement the kind of behaviors and therapeutic handling which make CP a way of life. And that's what I'm going to be discussing as part of our intervention. So, we need to face reality. Who of you have worked with children like this for longer than 5 years? Longer than 5 years. You're all very young in your careers. So I've been in this field for about 30 years. And it's been incredibly painful to see what happens over time. So this was a young man that I treated when he was about 7 or 8. And there he is, able to stand up in a standing frame. Legs were straight enough to be able to stand. The picture on your right is what he looked like 10 years later. Same child. Here he is again when he was a youngster. His arms were straight enough. He could straight enough to be able to take some weight through them. He was able to stand with some support, so that middle picture on the left, his mother's absolute delight when he was able to stand. And the picture on your right, that is what he looks like today. Same child. What happened from when he became a child to when he became a teenager? And what do we need to do when he's a child to try and minimize what happens to him as he becomes an adult? This young girl, her picture is on your right. That's what she looked like when I saw her, and I thought, oh, very severely disabled. And I asked her mother for photos. What did she look like when she was younger? And that's her picture on the left. So on your left, when she was younger. Okay. So a child who may be moderately disabled when they are younger, the cruel error of time. What happens as they get older? Okay. Again, the same youngster. This is someone that I worked with when she was little. We made a special chair for her to sit in. As she gets older, remember, as the child gets older, her parents, who are her main caregivers, get older as well. So their life becomes even more difficult. It doesn't get any easier. The child is bigger, heavier, less able to move. It's easy to move and pick up a young child. It's much harder to do it with an older child. So the child gets less and less access to therapy unless you've got therapists that go to the house. This young man on your right, that's what he looked like when I saw him. And yet look at the picture of what he looked like when he was younger. Okay. And I think you'll agree, the picture on the right, that's a photograph. I asked him for a picture of what he looked like when he was younger, and he showed me. So this is a young man who has a severe physical impairment, but cognitively, he is fine. Okay, he's able to play chess. So what happened between when he was sitting in that wheelchair to what became older? And I think even as he sits in that wheelchair on the right, you can begin to see some little hints of what may go wrong. And the most important thing that you can see from that picture on your left when he was young is that he's not being positioned well in a wheelchair. He's been given a wheelchair, so at least he's not lying on the ground, he's sitting. But is that wheelchair holding him in the best position possible? Yes or no? No. So being placed in a wheelchair, it may have made it easier for his family to move him around, but the wheelchair actually contributed to his contractures and his deformities. Okay, so I've given you some examples of negative change. But change can also be positive. And here you have Michael, who you'll be seeing quite a few pictures of Michael. Michael has not lost any of his abilities. We've been able to maintain Michael. Another success story is Desiree. So there's 10 years difference between those two slides. And there's Desiree still able to sit. She hasn't grown much. Desiree is now 21 years old. Still able to sit pain-free. We have maintained her. That, for me, is the result I'm looking for, where you can maintain something, the child is still leading the best quality of life. So, remember what I said, the cruel error of time, having a look to the future, what's likely to go wrong, and what does that mean for what we do with the children now. Think about the burden of care for the caregivers. The children get older, stiffer, heavier. And then what we're going to discuss now is what sort of behaviors and therapeutic handling do we need to do. So for the rest of the session, these are the points I'm going to go through. These are the guiding principles that I hope will help you, whether you're a teacher or whether you're a psychiatrist, physiatrist, or a therapist. There are 7. Firstly, work in partnership with the parents. Understand the child's body. What's likely to go wrong over time. Establish a connection with the child. Ensure that a 24-hour postural management program is in place. Facilitate safe eating and drinking. Someone mentioned safety. Therapeutic handling in everyday activity should become a way of life. And how do we encourage participation? So, I'm going to start with how we work with partnership in parents. And I'm noticing that we've been busy now for 51 minutes. So you haven't been moving. Are you feeling a bit stiff? Why don't we stand up? 2-minute stretch break. How does that feel? You're now a little bit more awake. We've moved. All right. So just the importance of movement and stretching for our own comfort. Okay, so the first principle that I'm going to tell you is about working in partnership with carers who in the most of the time are your parents, the mother or the grandmother. I want you to see that word partnership. You, as the teacher, as the therapist, as the student, do not need to have all the answers. Only a parent has got the lived experience of what it is like looking after a child with such severe disabilities. That parent has had to problem solve how to dress, how to undress, how to wash, how to recognize the child's in pain, how to recognize the child is hungry. That parent knows that child better than you will ever know. So that parent is your partner. Don't be shy to ask them and work with them. You're a team. As a therapist, yes, I'm a professional. I am not a mother. I have never looked after a child with a severe disability for 24 hours. I would be terrified. But I have got 30 years of experience of working and helping children with severe disabilities. So between the mother who has the lived experience and myself, we work together. I don't have to have all the answers, but we work as a team. Family-centered practice, mean that the parents want the best for their child. So I cannot, and I think if you're working at a school or an institution, it must be really hard to work with this group of children because there's no family there. Okay. Working in partnership is based on a relationship, and that's what I do as a therapist when I'm working and training other therapists, is to recognize the value of the carer, the parent of the child. That if we are going to work together, we have to have a relationship that's based on mutual respect. My respect for her as a person that knows her child best, wants the best for her child, and has the lived experience of caring for her child. I have the experience of working with many, many, many children. So we have a mutual respect for each other. One of the ways, there are simple ways that I think of when I want to help establish this relationship. I'm not sure how it is here in Saudi, but back in South Africa, where we work a lot in cross-cultural settings, where we work a lot with different languages, it becomes difficult to always remember the parents' names because the names are in a language that's unfamiliar to us. And so what therapists tend to do is to just call the child mommy, or the grandmother is gogo, as if that mother does not have a name. So one of the first things I do when I establish a relationship with the parent is to ask her, what shall I call you? Mrs. So-and-so, or your first name? And I remember, if I can't pronounce her name, I'll write it on a little sticky label and I'll pin it on her shirt while I'm working with her so that I can remember and I can call her by her name. I always have my name on me and I make sure that that parent knows my name. It's just a small little, for me that's the starting point. It's not mommy and therapists. Okay? It's Rose and Gillian. Understanding what the child's body is always doing and how to make movement easier for the child. Now, this is the strength that therapists will have, particularly if you're a physio, OT, or speech therapist that have had some training in Bobath or NDT. You'll understand, you'll be able to analyze things at great depth at the level of the impairment. So, very briefly, we need to understand what this child's body is always doing. I'm using very simple language because this is how I work with parents. I need to be able to take something that's really complex, explaining things like asymmetry, okay, or what the muscles are doing, and put it in a language that makes sense to parents. So what is this child's body always doing? Well, his head is always turned to the left. His eyes are always looking up to the side. The one side of his body is always bent. His hips are always twisted to one side. Okay. So I need to understand if this child, and this is me talking as a therapist, is this child spastic or is this child dystonic? I need to be able to classify the child according to his clinical subtype. Because the way that I handle a child who is stiff will be different to the way that I handle a child who is dystonic. When we work with children, in order to make everyday activities easier, we need to try and help the child's body to be as relaxed as possible in order to make movement as easy as possible. How do I make the child's body relaxed? There's not a recipe because every child's body is different. So I need to know, is a child more spastic or more dystonic? And by understanding if the child is more spastic or he's moving too much will give me a clue or a way into saying, this is how I need to handle the child. So here's a little example. So children who are stiff, those are all pictures of children who are stiff. You can recognize a child who is stiff because the arms and legs they're always stuck and they're stuck in the same position. Always bent. If the child is sitting or lying, the limbs, the arms and legs are in the similar position. So, children who are stiff, we need to make them loose. Right, that's the first thing. If he's stiff, I have to help make the child looser. How do I make the child to be loose? There are 3 things that I do. Movement and rotation. Hypertonus, another word for spasticity. To move and rotate, to twist. And just think that's exactly what you did when you had to stand up. You stood up, we twisted, we moved, we stretched. The same principles you use for a child who's really, really stiff. You want to twist them, you want to move them, and you don't want to move them up and down like that. That's just going to make them stiffer. You must move them in a relaxed way, combine that with stretching and twisting. And I'm going to show you a video clip of that now. Okay, so movement and rotation. Think about that. You move and you twist. All right? Combined with massage and stretching. And it's not massage and stretching on its own. You want to massage and stretch because that works on the non-neural element. That works on the muscle length itself. You're changing the muscle, making it softer by your massage and your stretching. But you need to add movement to that. Okay. So these are examples of how we have taught this child's mother to do that program daily at home. How she will have a program every day of where she stretches, she twists, she massages her child. Just look at that picture there. What I love about that picture, I want you to look at the child's eyes. Can you see the child is actually looking to her mother? And that's important. When you twist and you massage and you make the child feel loose, you don't do it in isolation. You do it as having a conversation with the child. You don't do things to the child. The child isn't someone that just is lying there and I'm going to do things to him. I work with the child. So here's an example of Rose and her son Michael. And this Michael was a picture I showed you earlier of a child that I think is a success story. Okay, Michael at this stage was about 12. And I want you to see a number of things as she moves him. Firstly, he's not crying. He's not in pain. Okay? Look at how she's working with him, how slow it is. Okay? So she's working at a pace that he can cope with. Not doing things to him, but working at a pace that he can manage. Okay? And this is just her simple massage and stretching program that she does every day. So she makes him comfortable. A little tip for therapists, if you're working with children, that we always start with the rib cage. As she was massaging and stretching and moving that rib cage, so that helps the child breathe deeper. These children are also highly at risk for respiratory infections. Okay, right. So just look how gently she's doing it. And as she's doing it, she's combining the twisting that arm out, doing the stretching. Okay. This is a labor of love. And it's something that's really easy to teach parents. Remembering also Michael's body is predominantly stiff. If he was dystonic or had sudden increases in his tone, she would be doing this quite differently. So although I say you've got to stretch and massage, it depends on the child's body as to how quickly or how slowly you do this. This will take her plus minus half an hour to do every day. This for me is one of the mainstays of maintaining the child's integrity of the musculoskeletal system. So keeping the soft tissue length. Okay? If she can keep the length and she can keep the range, things like dressing and undressing will become easier because the limbs are not tight and not stiff. So we want to keep the child as loose as possible. CP does not take a holiday. This has got to be done daily for the rest of the child's life. If I, a therapist, expect the mother to do it, I need to be able to make sure that I'm encouraging her. Encouraging her saying, this looks great and don't give up. She won't be able to see any change or any difference. But if she stops doing it, she'll soon see how quickly the child becomes tight. Okay. So this is a program that she was taught and how to keep her son loose every day. And I just want you to notice how that Michael is not crying. He's not crying. He's not getting stiff. Okay. I'm not sure what's happened to the volume here, but if there was audio here, what you would hear her doing was she would be explaining to Michael the whole time, this is what I'm doing. Because Michael also has quite a severe visual impairment. Okay, all right. Okay, and then I just want to show you some more ideas of what I would do as a therapist to try and help him to be loose. Okay. So the things that I'm doing there as a therapist, and the only reason that he's undressed there is to make it easier for you to see what I'm doing with my hands. Across his waist is a towel that I'm sitting on, and that just gives me support that I've got something that holds his pelvis in place. Because as I'm moving his rib cage, I want to move his rib cage over his pelvis. I don't want his whole body to move. So if you want to be effective in how you loosen a child, it's about moving one part of the body against another part. So you have a part that's stable and a part that moves. So I'm moving his chest and his rib cage over his pelvis. So keeping the bottom half still and twisting, stretching, rotating the top half. I'm doing a combination of things there with my hands. I'm stretching, so my hands are on either side of his rib cage. So I'm stretching his body up. While I'm maintaining that stretch, I'm then, as you can see, they're twisting the body from side to side. And earlier on, I was moving the body from side to side. Remember the things that I said, if you want to help make a child's body loose, you've got to massage, stretch, move, twist, or rotate. Okay, those 4 simple ideas, whether I'm doing it to the body, to the arm, to the leg. Okay, what I don't do is this movement. Okay, this is called a passive movement, and all you're going to achieve with this is what you think it's going to do. Make the child stiffer or looser if I do this. Stiffer. Okay. Do you still get taught this? I know in South Africa they still love teaching students this. Passive movements are fine if your limb is totally paralyzed and there's no movement. A limb that's got increased tone that you start doing this with, all you're going to do is make that tone higher and make it more difficult, and so the mother's going to use more force to do it. Okay. Okay. So I was just changing the position of the legs. I wanted the legs to be a little bit more apart. If Michael is looser, it's easier then to position him in a good position, sitting in his chair or sitting on the sofa or wherever he's going to sit. So there's just some more ideas of how slowly you've got to work with him. And you notice also, I hope you can notice that his arms are relaxed. They're not pulling up. Okay. Right, so let's stop that one there. Okay, so what did I say? No passive movements. Right, I don't often say there's rules that or things that you shouldn't do, but I can tell you now for children with CP, no passive movements. Right. So that was the first. I've given you we're going through 7 different things with the child, guidelines. The first one was, what was the first one? First guideline, working with the child. Severe disability is establish a partnership with the parents. Okay, you're working together. Sorry? The relationship. Establishing a relationship between you and the parent and the mother. Sorry? And the carer. Carer. Yeah, and the family. Okay, that you are a partner. And the second one was, you must know, and this is particularly for therapists, understand the child's body. Is this a body that's more spastic hypertonus, or is this a body that's more dyskinetic and moving around too much? And the way that you handle each will be different. And I'm talking for the non-therapists here in the room. A therapist should be able to help you and say, this is the way to handle the child. This is the way to hold him. Then the next thing, one of the hardest things to do, is to establish a connection with the child. Notice I'm not saying necessarily communication, I'm saying a connection. Firstly, expect a response from the child. The child, every child, does communicate in some way. We often miss the signs because they're so subtle and so fleeting. I will ask the child's mother, because the child knows the mother best. The mother knows the child best. How do you know that your child is hungry? How do you know that your child is in pain? And most often it's a facial expression. It's a facial expression, or the body becomes a little bit tighter. So as I work with the child, what I'm doing is I'm responding, and I watch the child's face the whole time. If I see that child grimacing, if I feel that child stiffening up, I stop. Immediately I stop. I stop and I say to the child, something is not right. I'm not sure what it is, but you are telling me that something is not right. So I acknowledge any little communication signal that I may not understand it, but the child's expression is changing or his body is changing. I stop and I wait. And when I see the child is now more relaxed and he stopped grimacing, I may change the position, I may change what I'm doing, then I continue. But that small little way of acknowledging and stopping what I'm doing, because I expect the child to have some response. I've got to find, the next thing is to find a way into the child. What is it that the child responds to? And we're going to have a look at vision. Okay, how much can the child see? So if you have a look at your different body systems, you've got vision, you've got movement, you've got auditory, you've got touch. Which system is a way into the child? If a child has got both a problem with hearing and a problem with seeing, maybe I'll use touch. I'll use something that vibrates. Something to see if I can get a response from the child. What is the response I'm looking for? A smile. Something, a little sound. Something that tells me he's noticed this. The parent knows the child best. So I may say to the parent, what do you use at home? What works? You know what they will often say? It's the cell phone. The cell phone that's got a light on it and it's got loud music. Your cell phone can become your best toy here. Okay, different music, different lights can often attract the child's attention. Music. Right. Then I have a look at a step further, once you've got a way of the child being able, or recognizing this child is trying, he's communicating some way, is to be able to, what we call, to shape that response. What I'm looking for in a child is to try and get a consistent yes and no. And that takes two things. The child firstly needs to be able to have some physical sign that he's saying yes or no. It may be looking one way. It may be it may be a smile. I don't really like using a smile because when a child smiles, I don't know if he's telling me he likes something or he's telling me yes. So I try to avoid getting a smile. Or I'll introduce the AAC symbols. A child may look at a happy face or a sad face. All right, a yes or a no. The child also has to have the cognition in order to make a choice, to indicate yes or no. So the concept of yes or no. The easiest way to do it is if I'm doing something to the child and he really likes it, I will stop doing it. So if I'm playing some music that the child really likes, then I stop playing the music and I wait. I wait. And I expect the child, because I'm thinking, I hope the child wants more. But until the child gives me a signal, whatever signal, until he gives me that signal, I won't put the music on again. And then the child learns from a cognitive point of view, oh, when I did that, she did something. So that early thing, if cause and effect. I did something, something happened. Because what happens with the children is that we don't give them time to respond. We decide, oh, you want some more, and I switch the toy on. So if we carry on doing that, the child becomes even more helpless. And we talk about a learned helplessness. Whereas if I stop and I say, I expect you to give me some response. I'm not even sure what the response is, but I look for any sign and I use it. So the child and I are kind of training each other. Okay. Because once the child can make choices, do you want this or do you want that? You've got a communication system. Do you want milk or do you want juice? Do you want to go inside? Do you want to go outside? Do you want to lie on your bed? Yes or no? Do you want to sit in the chair? Yes or no? Okay. A yes and a no, or the ability to make choices, is the most powerful tool. So for teachers, that's what you also have to try and say. How does the child indicate yes? How does the child indicate no? With communication, where do I start and what should I do? Number one, expect that he's got something to say. Number two, get into the right position. If you've got a child sitting down there and you up here, you need to make eye contact with the child. So get to where the child is. So here's a little picture there. The child's on the floor. That's the child's mother making eye contact. So you need to try and get the child's attention, and you need to try and get that eye contact where you can have face-to-face contact. Get the child's attention. And then you mustn't just tell the caregiver what to do. How I work with the child the whole time I'm interacting with the child is modeling. So I make sure, am I in the right position? Am I trying to make contact? Am I at eye level with the child? Am I trying to find a way to get the child's attention? And what will get the child's attention? Is it a light? Is it movement? Is it vibration? I then acknowledge and reinforce any attempt that the child has at making communication. I will acknowledge it. Yes, you slapped your tray of your table. You knocked your leg. You turned your head away. I will acknowledge it. And that acknowledgement and then reinforcement will lead to that link between when I do this, it means that. And when I said earlier that working with the children, we want to change behavior. So it's about using everyday activities. Dressing, undressing, washing, bathing is the best chance that you've got of communicating with the child. And yeah, we can spend a whole lecture just talk about communication, but it's about pouring language into that child. Because the child doesn't talk to you, we stop talking to the child. Okay. Right. The next thing, another way into the child, or to try and get the child's attention, is through the visual system. I mentioned earlier on that most of the children that we're talking about in this group will have something called a cortical visual impairment or cerebral visual impairment. This isn't specific to children with CP. People can be walking around and have a CVI. But children who level 5, GMFCS level 5, this is the most common visual impairment that they'll have. And what it is, it means that there's nothing wrong with your eyes themselves, but the interpretation. So if your visual cortex is damaged, your eyes can't make sense of the information they're receiving from the outside. And that's what makes this really difficult to try and get a handle on. Because sometimes it looks like the child can see, and sometimes he can't. The child might go to an ophthalmologist, and the ophthalmologist will say, there's nothing wrong with the child's eyes, but yet the child can't see. Or he can see some things and not other things. Or the mother will be told the child is cortically blind. Okay. So recognizing that a large proportion, I'd say well over 80% of children who are the severe max level 5, FCS level 5, cognitive involvement, epilepsy, will also have a CVI. Some of the signs that you will recognize is that the child has got the so-called non-purposeful gaze, well, often towards a light source. So the child's eyes will drift up and they'll be staring, whether it's the light at the room, the light from the ceiling, or to an outside light source coming in from the window. Okay, they just they're aware of the light and they'll just start passively staring at the light source. There's a color differentiation. The children tend to see red and yellow more easily than something like blue and green. And you get different degrees of CVI, from a severe CVI to a very mild CVI. So a child may see the red cup more easily than the blue cup. Okay, or something that's red and yellow more easily than something that's blue and green. And then you've got unusual visual motor behaviors. And there's a picture here that will show you. So the child on your left was being passed a paper. She looked at it, and as she took the paper, she looked away. Her visual system, the visual system can't work together with the motor system. So I look at something, and when I take it, she turns away. Okay. And it's very strange because you think the child can see something, and as they reach for it, they look away. That's a very common sign of a child with a CVI. And then you've also got the child on your right, an example of the passive staring. Difficulty with visual novelty. So the child, things that are unfamiliar, things that are familiar to the child. So a particular toy that's always in his cot. He'll be able to recognize that, but may not recognize a new toy. So we sometimes call CVI piecemeal vision. Sometimes he can see and sometimes he can't. So the things that are familiar, he'll be able to see. Certain colors he'll be able to see. often they can see close by and not far, and they can see more easily on the periphery and not centrally. So when you're trying to work with vision, you may often introduce something on the periphery and move towards trying to work towards the center. So the visual system, it's another way in. And I think if you're a teacher, it's really, really important for you to understand what the child can see best. What color do they see best and where? In this side, that visual field, down there, where do they see something best? Because that's where you need to position their work and what you want to give them. Difficulty with complexity and crowding. So we can use the example of going into a football stadium that is now full of people. Now, your football stadiums, understand now, both men and women are in football stadiums. Is that right? So you'll go into a football stadium that's full and you want to try and find your brother. No ways. If the stadium is empty and the only person sitting there is your brother, will you find him? Yeah. So that's what we talk about, visual complexity. Or if the football stadium is full and someone shines a spotlight on your brother, you can see him. So that's what we mean by visual complexity. So another little tip for treating children with a CVI is make sure that you're not presenting, objects against a plain background. You're not going to wear a shirt with lots of stripes or colors on it and then try and present the child. They won't be able to see the difference. When on their desk must be clean. Not lots of other things on their desk. Or if they're eating off a plate, put a red plate on a contrasting surface like a yellow surface so it's easy for the child to see and to pick up. Okay, so some of the therapy strategies, you've got to do a detailed visual assessment, and you normally need someone that's specialized in working with children with a CVI to help you there. What's the color preference? Which color does the child see best? And it's often a contrast, so black and white, red and yellow. Movement, you may use movement to get the child's visual attention. Give the child time to respond. They may not. Latency means you can present the stimulus and it will take a while for the child to actually notice it. Use familiar objects and use a plain background. Now, one of the best strategies that I use for your level 5 children is something called a vision box. Wait, I'm just going to stop there. So that's what a vision, it's very, very sophisticated. Hey? Cardboard box, that's what we call it. A cardboard box. The cardboard box must be, the size of the cardboard box is quite important. It needs to be just a little bit wider than the child's shoulders. It needs to be high enough so the child can reach, and you're going to put something dangling from the ceiling. As you can see, something shiny. Okay, and it's going to be long enough that it covers the child from his head to his hips. So the child lies in this box, and then you can put 1 or 2, not more than that, toys. And what this box, it's an amazing piece of equipment that you can use for children with CVI because it shuts out all the extraneous noises. And so the child, it's easy for them just to isolate their visual system, to be able to filter out all the other noises, to filter out movement, so they can just focus on their visual system. And so this little boy that's reaching, he doesn't reach. He only reaches if he's in that vision box. So let's look at Michael here in his vision box. This was the little boy whose mother was doing the massage. He's got a severe corticovisual impairment. So I want you just to see if we can play this.
Okay, so we can start, Rose. Start.
There's nothing in the box. She's only using a light. And I want you to watch his face very, very carefully. Can you see how long it took for him to start seeing it? He's looking and smiling. That's when I say we celebrate tiny things, that's what we celebrate with Michael. That he could pick up that light, source, follow it, make noise, and smile. You know what that must mean to his mother? That as your child has noticed something, it's given him pleasure. He's enjoying it. Okay. Right, postural management program. Okay, I said the children can't move. They are going to get stuck in whatever position they are left in. 24-hour posture is for your GMFCS level 5 is a way of life to be taken seriously. And you as the therapist or the teacher need to make sure that the equipment's doing what it should be doing. And wherever the child is, he needs to be properly positioned. This is your absolute basics working with this group of children, particularly if you're a therapist. So to give you some ideas, is that good positioning? Do you think useful? Good. Thumbs up, thumbs down. Your switch toys. I didn't show you that, but it's the same idea that the child learns if I push this button, something happens. So that's where technology comes in, is incredibly helpful for this group of children. Positioners, I work in a resource-constrained setting, so we just use what's available, cushions and pillows to place the child in a correct position. I want you to see the difference. So this lady in green is a parent, the lady with the green shirt. She's a parent of a child with a disability that we have trained as a peer supporter. So she was doing this home visit with me. When we got to the house, the picture on your left, that was how the mother was holding the child, compared to a more therapeutic way of handling. Something really, really simple. Position the child all the time in a helpful position. Right. I'm going to show you a picture of Michael's mother again, how she positions him. Earlier on you saw her do the massage. Then you saw her doing the shining with the torch, the vision box. And this is now how she's positioning him. I also want you to notice how carefully she handles him, how slowly she goes, and how she's talking to him. So she's communicating with him the whole time. He may not respond, but he recognizes her voice and he recognizes her touch. And because of that, he's just a very relaxed child that I know is comfortable and not in any pain. Okay, I'm just going to move on. Okay, and there's another position. So they're positioning on his back on the bed, or here's a way of him lying on his side. He was watching TV. A beautiful position, and we teach them what do we mean by a good position and what's the best position for your child. And that goes back to understanding the child's body. Okay. Right. We are getting towards the end. Safe eating and drinking and optimal nutrition. Here is where you may need the support of the experts, dysphagia experts, to help with swallowing. The ENTs, the children need video fluoroscopies, and most of the children will probably end up with a feeding tube for safe eating and drinking. The places where I work, we can't always get, it's not always possible to get a feeding tube. That's why we do our best to give the mother some tools, to have a look at the right positioning, safety, and some techniques. Right, so drinking from a cup. There's a grandmother who's learned how to feed her child in a good position. Okay, so problem solving for each child, the best position and some techniques for doing it. Okay. Right, dressing, therapeutic handling in everyday activities, dressing and undressing is the best. Why do you think we want to do it in sitting rather than lying? Any ideas? It's easier to do it in lying. It's easy. We say if you want to make therapy and good handling part of a way of life, dressing should be done in sitting. Gravity. It will make it worse. Yeah. Yeah. Well, it may be harder because the child doesn't have any balance. So now you're trying to sit and hold the child. But from the child's point of view, it allows the child to be more active. When he's like, who do you dress on the bed? A baby. A baby or an old person. We are dealing with children and teenagers. Work with them. Treat them as a child. So if I help the child to sit, firstly, the child's more active. I'm also, by the way, looking a little bit at working on sitting balance while I'm doing dressing and undressing. It makes it so much easier for the child to participate. So here's a little bit of how Rose was dressing Michael. Okay. Can you see how she's turning his hand? So doing the little stretch, doing it in a helpful way. Okay, this is what we call therapeutic dressing. So while she's dressing, Michael's sitting, using his head a little bit, getting some trunk control, looking around a little bit at what's going on. Okay? It's not passive. And she can do a stretch at the same time. So make therapy part of everyday life and everyday activities. All right. And then, lastly, participation. Participation is one of the hardest things, I think, for a child with such severe impairments. Visual, cognitive, epilepsy, and motor. Communication is your way. And if you can establish a connection with the child and get a yes or a no, I like it or stop it, you can get participation. Okay. I'm going to show you just a little clip of siblings are the best. Siblings. Right. Yes, they may not understand why their brother's not talking, but they're the ones that I find always want to include the brother and try and make participation possible. Okay. All right. Okay, and lastly, these slides are always to show you that connection and that bond. And one of the biggest gifts that we can, as professionals working with children with severe disabilities, is how do I make it possible for the mother and child to have a relationship where the mother has pleasure out of her child rather than feeling, I don't know what to do, I don't know what the child's saying, and I'm feeling guilty in some way. So all these pictures just showing the joy that parents get from their children. And I hope that with the tips that I've given you, working partnership with parents, understanding your analysis of what the child's body is doing, establishing a connection, ensuring there's a 24-hour postural management program, facilitating safe eating and drinking, therapeutic handling, and participation. The key messages I want you to take away is to think holistically, and that's what you told me in the beginning. Get the basics right, the basics simply of positioning and keeping the child's body as relaxed and loose as possible. Think about what's going to happen in the future. This child is going to grow and get older. Notice and celebrate the little changes that happen. Work in partnership. You're a team with the child's mother and family. Never give up. Change is possible, and work for the best quality of life for both the child and his carer. So, I showed you these questions at the beginning. Can we expect change? Yes or no? Yes. Both negative and positive. What changes are likely? Small changes. When should the child be discharged? Never. Excellent. What's the point of therapy? Quality of life of both the child and the carer. So, I thank you for your time and attention today, and I also want to say thank you once again to the organizers for allowing me to be here with you today. Thank you.
Excuse me, Doctor, I have one question.
Yes.
مستشفى الملك سعود العنازة. طبيب أنا. Yeah, excuse me, sister. My question is that point of the principles of how to deal with that patient with cerebral palsy. That means depend on my classification to deal with that patient according to that severity. Is it that spastic or pyramidal or that hemiplegic or that monoplegic or quadriplegic? According to what? To the severity or to the general condition of the patient?
So that's a good question that you ask. I didn't have time to go into that, but that would be a therapist that's trained in working with children with CP will learn the difference between a child who's spastic and a child who's dystonic. That's the basics. So that a therapist should help you with to get that. Okay. There are some signs, but that we could do a whole lecture on its own. But basically a child who is stiff is a child who's in the same position the whole time. A child who's dystonic, one time the arm might be up there, another time it might be there. The child is more asymmetrical. The child who's dystonic is also a child that pushes back very strongly. That's very simply it. Okay.
I want to ask about the first box. We put many things and to...
The vision box.
The first box.
Yeah.
You fill in the picture, you put many things and want to the child to hand.
To do with the vision.
To take the things?
Yes, okay.
Can you explain this?
Oh, the vision box. Okay, I don't know if you said vision or first, sorry. The vision box, so I've told you about the size of the box. The size of the box is important. Okay, and then you hang something above the child's chest level, so where he can reach, all right? The things that you hang there, all right, can be something that's shiny. A shiny toy, or even some shiny tinsel paper, shiny wrapping paper, a shiny CD. You can also think of a bell that makes a noise, so that when he knocks it, it makes a noise. All right. So I think both of some, and I would only put 2 objects there, not more than 2. Something shiny, and the other thing might be a soft toy that when he knocks it, it makes a noise. Okay, and normally in a color that he might recognize, red or yellow. And you can change the objects. Every week you can put something new in. Sorry? Yeah, anything because you want that if he does something, it gets a response. That he said, oh, I felt that. It tinkled. Or it moved, so I could see the reflection. Yes.
Is it based on a sensory integration approach? That box.
Sorry,
Is it based on sensory integration approach, or on which approach?
You know, I don't think it's one approach on its own. I think there's lots of different ways of explaining it. I think in some ways it could be sensory, but you're trying to shut down because so the child only can process one system at a time, but you can use the system of movement to attract the child's attention, to get him to use his vision.
Okay, but I have another question.
Yeah.
About the best approach, like Bobath or BNF with the CB.
Bobath or?
BNF.
All right. So I wouldn't say that it's either or. For me, I have a look at a holistic picture. And the things that I'm doing here, some of them are Bobath and some of them are not. I take what works for this child.
How to decide? Because some patients really, like stage 5, they are difficult to, like if they are too spastic.
Sorry, just say that again. If
the patient too spastic or the child too spastic.
Yeah.
The goal is just to inhibit the tones, huh?
Yeah. So what I said was, if the child, you've first got to make sure that he's dystonic and not spastic. A lot of dystonic children look spastic. So once you decided he's spastic, I've given you 4 things that I know reduce tone, which is massage, stretching, movement, and rotation. There may be other ways of reducing tone. But the main thing is to reduce the tone and to help the child feel loose.
So only the goal to reduce the tone.
For that child to start with, if I want to make it more comfortable, make it easier for him to try and move a little bit, make it easier for his carer, then I have to make his body feel easier to move and be moved. And there may be more than one way of doing it.
Okay, thank you.
Okay.